giving me this opportunity to be part of this very, very prestigious conference. And most important thing is that being with two legends in the field of nephrology, Professor Groove and Professor Tripathi, I think it's a huge privilege for me. Task assigned to me is whether CKD is equivalent to high CV risk and whether it is a single disease spectrum. So what I'll be doing is that I'll be doing the conceptual part, because after this, Professor Tripathi and Professor Groove are going to take you through what to do to check this progression of cardiorenal continuum and how we can prevent not only CKD but also subsequent CV outcomes in high CV outcomes in these patients. So I'll be doing the conceptual part, and I'll start with the basic definition of kidney disease. We know chronic kidney disease is abnormalities of kidney structure or function for more than 3 months with its implications. We know diabetic kidney disease, we say when disease is specific to diabetes, with primarily diagnosis being based on presence of albuminuria, which is one of the core component. And of course, diabetic nephropathy, when we know the kidney disease is caused by diabetes, a kidney biopsy may be helpful for a definite diagnosis. But mind it, the terms DKD and DN are often used interchangeably. Both ultimately lead on to chronic kidney disease. So I'll be referring it to only as CKD. 2013, KDO classification said that we can stage CKD based on EGFR as well as on basis of albuminuria. And what it said that G1, which is a normal EGFR category with normal or high EGFR more than 90. G2 is when there is a little decrease in EGFR, it is between 60 to 90. G3A and 3B are important because there is going to be a mild to moderate reduction in EGFR by almost 45 to 60 and 30 to 45. Of course, G4R when there is a severe reduction in EGFR, and G5 is it is end stage renal disease with EGFR being less than 15. Similarly, based on albuminuria criteria, category A1 is when you have a normal or mildly increased albuminuria, only less than 30 milligram per gram. And when you have moderate increase, 30 to 300 milligram per gram of creatinine, it is A2. And if it is obviously more than 300 milligram, which is a gross proteinuria, we refer it to as A3 category. Why this categorization is important? Because moment we know that you are falling in the category of G3A, 3B, 4B, or albuminuria category A2 and A3, there is going to be a progression of CKD, and it is going to have poorer prognosis. So if you are anything between G1 to G2 with a normal albuminuria, you are falling in the category of green box. That means you have a normal outcome and it may not progress at all. But moment there is a reduction in EGFR and falling in the range of G3A, 3B, especially with proteinuria, either mild or moderate or severe proteinuria, then there is going to be a increase in CKD progression, and it is going to carry a very, very poor prognosis. We all know that it is primarily diabetes, which is one of the most common cause for progression to end-stage kidney disease. Almost 40% of these patients, they tend to be diabetic before they have end-stage renal disease. One of the studies from US said that 50% of patients ending up with hemodialysis are diabetic. Well, diabetic kidney disease occurs as a consequence of multiple pathogenic mechanisms, although we usually blame it to hyperglycemia, but believe me, it is probably much more than hyperglycemia and many more contributors towards CKD progression. Even if you compare South Asian versus Caucasian, there is a very high predisposition for CKD in South Asians. It is almost fourfold higher as compared to Caucasian in terms of developing albuminuria. Not only that, there is a higher prevalence of advanced CKD. Stage 4 and 5 are very, very common in Asian patients. And possibly, well, there are multiple genetically predisposing mechanisms. It could be a defect in RAS, inflammatory pathways, cytokines, dopamine, rage, oxidative stress, and many more pathways contributing towards progression of CKD in these patients. But definitely, moment you have markers of DKD, which is, as I said, declining EGFR with worsening of albuminuria, it is going to be associated with increased mortality, increased renal events, increased CV events. Even CV death will go much higher, and there could be an impaired cognition also moment you have advanced or DKD in these patients. We know that risk of even renal events increases moment you have this increase in albuminuria or reduction in EGFR. So anytime your EGFR goes less than 90 towards 60 ml, or you have albuminuria going towards gross proteinuria, there is going to be increase in events of overall renal components, or renal composite endpoints are also going to be increased. Another US population based study on 15,000 patients concluded that progression of DKD is associated with increased mortality. So if you have only diabetes, fortunately mortality is not very very high. Moment you have simply an albuminuria present, or you have a reduction in EGFR, or both reduction in EGFR to less than 60 ml and albuminuria may be moderate or severe or gross proteinuria, almost there is a 10 times increase in overall CB risk or cardiovascular mortality. So diabetes has a very very dynamic relationship. It is something like heart failure and renal failure, and these are or sort of worsening each other. What is these days we say a cardio-renal or renal-cardial continuum in the setting of type 2 diabetes. It's a very, very dynamic relationship with persistent hyperglycemia. Not only you have oxidative stress, which induces inflammation and then leads on to cellular apoptosis, which then leads on to gradual nephron loss, setting in stage for renal failure. And similarly, there is also going to be a cardiomyocyte loss leading on to rampant heart failure or a manifest heart failure in these patients. But believe me, there are three major mechanisms which underlie the cardiorenal syndrome with the hemodynamic component. The first one, which is going to be extremely important, and actually it is the hemodynamic mechanism or the component which drive the connection between heart failure and CKD. It could be in the form of a fluid overload and retention of salt and water. It could be renal and cardiac congestion, what we normally say renal venous hypertension, which then leads on to a forward failure, a limited organ perfusion, a peripheral resistance, which then leads on to increase in vasoconstriction and which then worsens heart failure also. But there could be neurohormonal mechanism like activation of RAS system or an overactivation of sympathetic nervous system in the presence of persistent heart failure, in the presence of persistent hyperglycemia, or it could be CKD associated mechanism like chronic inflammation in CKD with activation of cellular immunity. It could be malnutrition, cachexia, wasting, or bone mineral disorder, or acid-base metabolic disorder also contributing towards progression of both cardiorenal continuum. So if you want to check the progression of cardiorenal continuum, even protecting the kidney may protect the heart and vice versa. It is true for both. We know kidney already has hypoperfusion. There is a ongoing apoptosis or necrosis or fibrosis or glomerulosclerosis. And I told you there is an overactivation of RAS system with sodium and water retention and huge amount of vasoconstriction which is there. So there are going to be compensatory mechanism to restore cardiac output in the form of increased venous pressure. What I said, renovenous hypertension or sympathetic nervous system with natriuresis. And we know there is a very close and specific association between cardiac and renal physiology. So if you revise your basic fundamentals of physiology, you will remember that moment there is a decrease in cardiac output, there is going to be a reduction in renal blood flow. So overall EGFR is going to be down. Initially, there could be a reduction in albuminuria, but with progression of CKD in these patients, there is going to be a further decrease in renal function. A sodium water retention is going to happen, which will then lead on to decreased cardiac performance and will worsen chronic heart failure. So it seems to be a dual dynamic relationship between worsening of heart failure, worsening CKD, and similarly onset of CKD also leading on to worsening of chronic heart failure in these patients. So it is not only CKD which increases the risk of CV events, but mind it, even the CV events, I'll be alluding to that, even CV events, they increase the risk of incident CKD in these patients with type 2 diabetes, especially with persistent hyperglycemia. So it's a cardiorenal continuum, which is an ongoing phenomena. Not only there is a risk of CVD and CV mortality, which increases with progression of CKD through mechanism like atherosclerotic cardiovascular event like CAD or ischemic stroke or PAD. In later stages of CKD, actually, it is a non-atherosclerotic risk which also dominates, which could be manifesting as LVH. It could be like arrhythmias. It could be a sudden cardiac death or arterial calcification or hemorrhagic strokes. So together, these contribute towards very high cardiovascular risk or mortality. So declining EGFR itself is a very strong risk factor for CV death and all-cause death. So if you follow this patient, moment your EAGFR starts coming down from 90 and it goes towards 60 or 45, not only there is going to be an increase in all cause mortality with onset of CKD, but even overall cardiovascular mortality is also going to be high. And it's a very wonderful data on almost 3 lakh patients who are non-hypertensive. And good thing is that they have already removed all the confounding factors or that bias because of hyperglycemia, maybe dyslipidemia because of BMI, albuminuria, other things have already been accounted for. So alone reduction in EGFR will lead on to higher CV death and all cause death also. Not only that, even persistent albuminuria, I told you, moment there is an increase in albuminuria from 30 to 300 milligram, there is going to be an increase in all cause mortality as well as higher cardiovascular mortality. Again, what was seen in almost 3.5 lakhs non-hypertensive patient after accounting for another or previous confounding factor. So impaired renal function possibly is itself a strong predictor of mortality, and then it could be even higher than presence of a previous episode of MI. Someone who has already had an episode of MI or acute coronary syndrome, we know they are at a very high risk for having a second episode. But believe me that a reduction in EGFR is even stronger. Moment you have EGFR close to 45, there is almost double risk of getting a second episode of MI, which is much more than having a history of MI in the past. So the presence of CKD is commonly associated with development of fatal CV morbidities, and this is what we normally say, that older patients with CKD are almost 6 times more likely to die of CV diseases than to advancement of end-stage renal disease or dialysis. This is what we tell our DNB students also, that a patient of CKD or end-stage renal disease will possibly die of a CV death than actually dying of any cause related to renal death or renal composite endpoints. So not only that, even increasing albumin creatinine ratio and declining EGFR not only increases CV death also, it increases the risk of heart failure also. So moment there is a reduction in EGFR and increase in albuminuria towards macroalbuminuria, there is going to be increase in 3-point MACE components. That is how all CV outcomes have shown that those patients who have presence of CKD, their 3-point MACE outcomes are much higher as compared to someone who has a normal EGFR. And it is the CKD which is the most important risk factor for CVD, because if you see the study which has concluded that CVD prevalence in patient with and without CKD, you could see. So whether you are talking of CAD, heart failure risk, PAD risk, or atrial fibrillation, or CVA, or stroke, or acute MI, moment you have presence of CKD, this becomes the dominant factor as a predictor of overall CVD and outcomes. So majority of CKD patient will die actually before progressing to end-stage renal disease or maybe requiring hemodialysis. So if you follow this patient for 5 years, you will see that 33% patient will actually die of CV death, and it is only 12% patient who will require hemodialysis and they go towards end-stage renal disease. Not only that, risk of mortality is also possibly related amongst these patients, that it is the, even in the CKD patient, it is the CVD death which is much more important than the getting the risk of cancer or other infection in CKD patients. Not only that, even the risk of heart failure is also, as I already said, other than CV death, which also correlates with declining renal function. So moment you have onset of microalbuminuria and going towards macroalbuminuria with reduced ejection fraction in these patients, you have onset of heart failure also. And most of the time these patients have reduced ejection fraction type of heart failure. Not only that, even CV death is also related to reduction in EGFR. So moment there is a reduction in EGFR, the probability of survival is going to go down in these patients. Contrary to that, again, it has been seen that CKD is a greater risk for heart failure compared with CVD. And it is, as I said, it is a reduced ejection fraction failure, which is much more prevalent in these patients of heart failure in CKD, which is much higher than the preserved heart failure. Conversely, even heart failure, it is not only the presence of CKD which is worsening CV death or risk of heart failure or 3-point MACE, but even presence of heart failure. That is why in the beginning I said it's a dynamic dual relationship between cardiorenal continuum in the setting of type 2 diabetes, because heart failure itself increases the risk of incident CKD of and further declining of renal function. So moment you have heart failure, the overall decline in EGFR is going to be much rapid as compared to someone who is not having heart failure, and these patients are obviously going to have much higher mortality. So it was very rightly said that chronic kidney disease could be a coronary disease equivalent, and a very good study which is a comparison with diabetes over a decade time, and again it was seen that the presence of CKD has hazard ratio 3.7, almost 2 to 3 times higher than having alone diabetes or than having a prevalent coronary artery disease in this patient. So moment you have CKD, it is going to be associated with the risk of death similar to that of established coronary artery disease, and it is much higher than that of alone diabetes if you don't have CKD or you don't have CAD. So moment you have CKD, you are even worse placed than having a coronary artery disease in the setting of type 2 diabetes. Just concluding, the risk of coronary events in people with chronic disease has been compared with those without diabetes, and it is a wonderful population level cohort large study with 12 lakhs patients who have been included in this analysis. And again it was seen the patients who had diabetes with CKD, they were at a much greater risk for myocardial infarction or all cause mortality. So this study concluded that chronic kidney disease could be added as one of the most important criteria for defining people at the highest risk for CV death or long-term cardiovascular mortality. So kidney disease today is taken as a risk factor for development of cardiovascular disease, and this task force recommended by AHA that patients with CKD should be considered at a higher risk for subsequent CVD events, and they should be managed accordingly. So if you today are talking of a cardiorenal continuum with a common soil hypothesis for not only development of hypertension, type 2 diabetes, rampant atherosclerosis, onset of heart failure, we know which happens almost within 5 years in 60% of patients, whether a manifest or a non-manifest heart failure with progression of atherosclerosis and LVH, not only these patients are at a greater risk for developing heart failure, and we know microvascular complication which follow a linear course in terms of progression over the time, and we are at a greater risk for developing diabetic nephropathy. But our own publication, which I'm not showing you, said that micro and macrovascular complication seems to be continuum. This got published in IgM 2016. That time we hypothesized that it is micro and macro which is a continuum, and today is, I'm very happy it is getting true with huge amount of evidence coming that it should be viewed upon as a cardiorenal continuum. And if you want to break this, we have to intervene early. I'm not going to talk about how to intervene at what stage we are going to intervene, because that Dr. Tripathi and Dr. Groove will take over. Thanks a lot for your patience is listening, and towards the end we can have some discussion.